Hello and welcome to this episode, the September 2025 episode of our Pallium Canada Echo Palliative Care Journal Watch. Today we have four panelists, three regular panelists and a guest panelist who's joining us today, and we'll be introducing everyone very shortly. Next, please. It's amazing how this has already been going for 2.5 years. We're going to go into our third year. And the numbers are increasing across Canada and the world in terms of the audience. Our Palliative Care Journal Watch keeps you up to date on the latest peer-reviewed palliative care literature. We're a group of faculty members across several divisions across Canada, mainly in palliative care. We monitor the different journals, both palliative care journals and also those that are not specifically to palliative care, but do publish papers that we think are relevant. On the slide is a list of the divisions that have in the last few months been particularly active in identifying interesting articles, and that includes University of Calgary, University of Alberta, Queen's University, the Hadassah Hebrew University in Israel, and University of Navarra in Spain. And with the assistance of the Palliative Canada or the Pallium Canada team, we review these journals, we get them in from our team members, and we then, as an editorial team of four people, select the top four that we would like to present in each episode, as well as 3 to 5 honorable mentions, articles that we wish if we had more time we would have presented, but in the absence of a lot of time, we do our best in at least bringing it to you. So we ask you please to join in as well. Next, please. In the functions, there is a place where you please feel free to chat, especially use the Q&A function. Ask questions or make comments related to the articles we're going to present. Just very quickly, the Palliative Care Echo project, which has funded our Journal Watch series, is funded through a 5-year national initiative from Health Canada. And we're very appreciative of the assistance we've received until now to allow us to make this happen. Next, please. So, as I said, we will be presenting our top 4 articles that we've selected and a list of honorable mentions. Again, please submit the questions through the Q&A function. And this session is being recorded. So when the session has finished, we will be sending the recordings to those of you who are present, as well as many, many others who've registered for the session, but are not able to be live, but do download it. And then remember as well that these sessions are turned into podcasts. And so if you go to the Pallium Echo website, you will find the previous sessions that you can stream and watch, and you can also download podcasts of the different sessions. And we would really encourage you to share this with your colleagues at work, with your friends, let them know about the Journal Watch, and advantages that we're hearing from people around the country in terms of articles that we think either will change our thinking on a topic, a treatment, an approach, a model, or can confirm something that we've been doing but perhaps have not had sufficient evidence until now. Good. So with that, let's move on. Next. I'm Jose Pereira. I am professor in the Faculty of Medicine at the University of Navarra in Spain. I'm the co-founder of Pallium Canada and scientific advisor of Pallium Canada. Leonie, would you like to introduce yourself?
Thanks. Yes, I'm based in Calgary, Alberta, and I'm the director and chief of pediatric palliative medicine for the Calgary zone and a professor in the Cummings School of Medicine.
Excellent. And our guest panelist today is Dr. Yoko Terumi from Edmonton. Yoko, would you like to introduce yourself?
I'm Yoko Terumi, based on Edmonton Palliative Care, primarily working at the Cross Cancer Institute at this point.
Excellent. And then Sharon, also in Edmonton.
Hello, I'm Sharon Watanabe, palliative care physician, also based at the Cross Cancer Institute and a professor in the Division of Palliative Care Medicine at the University of Alberta.
Dr. Aingaran Sinaraja, who usually joins us, is one of our editors. Unfortunately, he's not able to join us today, but he has provided some input, and so we'll obviously be using that as well. Next. Very quickly, some disclosures. Palliative Canada is a foundation. It's a registered charity. Over the years, has received funding from different sources, including Health Canada. This ECHO-related program specifically has received financial support from Health Canada. In terms of the conflicts of interest, none of us have got any conflicts of interest to declare with this specific episode. Next. So, the list of featured articles, drum roll, and the featured articles. So there are, again, as usual, a spectrum, and we're looking at neuropathic pain. We're looking at home care and what are the factors that support home deaths and home care for patients with palliative care needs. There's a topic around preoperative, or an article around preoperative palliative care needs of patients, of elderly patients undergoing surgery, an area we often forget about. And then we're going to finish off with a fantastic recent clinical trial related to agitated delirium. So with that, I'll hand over to Yoko. Next.
So the paper that is presented here is an article published by international authors, including the Solomon in Lancet Neurology 2025. And it's been available online and open access. And background of this paper, including neuropathic pain caused by a lesion or disease of the somatosensory nervous system, substantially affects patients' quality of life, and it impacting on substantial economic burden and the individual and society. Regardless of the etiology of the nerve damage, the treatment of neuropathic pain is very challenging, requiring accurate diagnosis and biopsychosocial assessment and application of the evidence-based recommendation, and consider efficacy and safety of available treatments. The Special Interest Group on Neuropathic Pain of the International Association for the Study of Pain published its first guideline in 2007, and with an update in 2015, incorporating the grading recommendations, assessment, the development, and evaluation. Since then, new pharmacological trials and neuromodulation techniques have been developed and evaluated, along with the updated safety data and advances in evidence appraisal methods. So this is the update version of the previously published guideline and systematic and meta-analysis. And this new version is again based on the wide databases, PubMed, Embase, clinicaltrial.gov, International Clinical Trial Registered Platform. Search date starting from 2013 to February 2024 to intend to update from the previous guidelines. And trial including participants of any age, any neuropathic pain, but excluding from the mixed etiologies of neuropathic pain with non-neuropathic pain syndrome. And also, those are not considered as a neuropathic pain, such as complex regional pain syndrome, low back pain without radiculopathy or regular pain, fibromyalgia, idiopathic or facial pain. And at least 10 participants per group has to be at the end of the treatment, and the pharmacological or the neuromodulation trial has to last at least for 3 weeks. And primary efficacy outcome is to evaluate the proportion of the responders, at least 50% of reduction in baseline pain intensity, alternatively 30%, or at least moderate pain relief. And risk difference and standard mean difference was calculated, and recommendation developed through the series of the expert consensus meetings and anonymous online votings. Next, please. A key result of this paper was that including 313 trials and 29 neuromodulation trials were included, 48,000 adults, male, female, almost equal representatives, and the sample size median was 96 participants, and trial duration was median 8 weeks. This assessed 89 pharmacological interventions and 9 neuromodulation interventions. And the top three estimated for the primary efficacy and safety outcomes are the tricyclic antidepressants. Number needed to treat was 4.6. Number needed to harm was 17.1. Alpha-2 delta ligands, pregabalin or gabapentin in North America mainly, number needed to treat 8.9, and number needed to harm to 26.2. Serotonin and norepinephrine reuptake inhibitors, number needed to treat 7.4, and number needed to harm was 13.9. Rest are smaller samples, and so the calculated samples was quite small, and so this key discussion point based on these results that this finding provided the basis for the strong recommendation of the use of the TCAs and alpha-2 delta ligands and SNRIs as first-line treatments, and weak recommendation for capsaicin patches, cream, and lidocaine plasters as second-line recommendation. The weak recommendation for Botox, repetitive transcranial magnetic stimulations, and opioids as third-line treatment for neuropathic pain. And evidence in this review did not provide sufficient confidently to make recommendation for the specific patient populations or specific type of the neuropathic pain. And the distinction between weak and strong opioids is increasingly questioned, and as the risks associated with opioid mainly related to dose and maybe duration. So with this opioid crisis in mind, all opioids were recommended to be restricted to the third line in patients with worsening pain who have not responded to other reasonable treatments, and with shortest duration possible, and early and ongoing evaluation should be needed to mitigate the risk. And although the effect size of the motor cortex M1 repetitive transcranial magnetic stimulation was greater than that of many other drugs, but this proposed as a third line owing to the low certainty of evidence and low availability and high cost. And cannabinoids received so-called weak against recommendation due to the multiple risks, and no conclusions for drug combinations based on the 2023 systematic review and meta-analysis. Combination of the antidepressants, alpha-2 delta ligands, or the both together are not showing greater efficacy and similar safety compared to the single drug. Next, please. The strength of this paper is that the recommendations are based on the quality of available evidence and expert consensus with representation from 13 countries and every continent. This updated guideline included sensitivity analysis to evaluate the effect of the potential biases and qualitatively assessed each treatment's adverse effects, cost accessibility. Additionally, lived experience partners were engaged from the inception. And it is acknowledged the increased risk of the TCA adverse effects in older adults, as well as increased risk of the drug-related death in people taking both gabapentinoids and opioids, particularly regarding pregabalin. This acknowledged the interpretation of these results and subsequent recommendations must account for possible limitations. And the limitation that they acknowledged in the study was that shortage of the data prevented the authors from analyzing dose-response relationship in each trials, and also notable lack of the detail regarding how adverse events were measured and classified and influenced on information provided in this review. Next, please. And additional comments is that there were major clinical trial, randomized and multi-center trial in UK based on the peripheral neuropathic pain on diabetic the diabetic neuropathy, combining either amitriptyline or pregabalin or the duloxetine. And this trial was published in Lancet 2022. But this systematic review paper that I'm presenting today does not mention on this trial. And also the practice impact on palliative care is that when taking recommendation on cancer-related neuropathic pain, one should consider that pure neuropathic pain is less prominent than mixed mechanism. So the application of this evidence needs a little more consideration. And how accurately palliative care practitioners are making diagnosis of neuropathic pain using NUPSEC criteria and selecting treatment options based on the evidence is currently not known. And availability of treatment modalities such as capsaicin patches, cream, and lidocaine plasters, Botox or repetitive transcranial magnetic stimulation in Canadian centers impacting on treatment decisions. This is it. Thank you.
Excellent. Thank you very much. That must have been a tough job trying to summarize that very large study. But just to remind ourselves again, essentially the NNT, the numbers needed to treat, is the number of patients that we need to treat for one to have an effect, a clinical effect as compared to a control group, whereas numbers needed to harm are the numbers of patients that are treated for one of them to experience an adverse effect as compared to the control group, right? So very nice way of comparing these different drugs. For me, I was going to ask you, it is a very broad study, right? And in fact, the authors, I think, do say that they don't look at specific patient populations. So they didn't specifically look at cancer, for example, which is a population we see a lot. And as we all know, in cancer, we often use the WHO ladder, first, second, third. When they're speaking of the first line, second line, third line, it's not related to the ladder, right? Just to clarify that. It's
right.
So in other words, because in the ladder, we would normally use a non-opioid, an adjuvant, for example, in the treatment of mild to sometimes moderate pain, correct?
Yeah, so this context, the application of this evidence is a little challenging, I found, but also increasingly the people with living with cancer, advanced cancer, could live with pure neuropathic pain related to chemotherapy-induced or the spinal cord compression, the paraplegic. So some of the people live with central neuropathic pain. So opioid may be increasingly less significant to improve the quality of life, but also the harm could be another issue. So the considering to primarily approaching with the non-opioid can be a potential consideration based on this review.
Good. Because the way I looked at it, it doesn't exclude opioids. In fact, I think in one of the tables it says opioids for select cases, which would be, I think, in the palliative setting, what we would see patients with very severe pain in the context of a serious progressive illness. And for that, when I look at the numbers needed to treat and numbers needed to harm, the numbers needed to treat are relatively high. In other words, let me rephrase that. It's pretty effective. It's
right. Yeah,
somewhere between the tricyclics and the gabapentin pregabalin.
Yeah, it's a number.
And the numbers needed to harm are not much higher.
Right. So I think the duration and the dose, as this paper also acknowledged, could also impact. So if we were approaching patients with end of life, for sure, this is probably not going to be the issue. But if you're treating people with many years ahead, that would be the challenge, I would think. And personally, I have explored this transcranial magnetic stimulation in Alberta, And this is
Yeah.
currently only accessible for people with the refractory depression. So I called around in Calgary and Edmonton centers, and one of our patients, the cross cancer, is not eligible because it's not a depressive mood, but we're seeking for neuropathic pain support. So unfortunately, the accessibility is really limited.
Okay. Sharon, Leonie, any thoughts around this article? What are your first reaction when you read it?
Yes, so really nothing to add. I guess as has been stated, the applicability in the cancer patient population is a bit more nuanced.
Yeah.
Yeah, my only thought was it would be nice to have teased out a little bit more of the different types of neuromodulation, but maybe there's just not enough studies because there's many more things besides TMS, and so that we use, especially in the context of like chest wall cancer pain, for example. So it was too bad that they lumped them all together, but maybe there'll be another review that looks at that specifically. Thanks.
They were looking at the scrambler therapy and the TENS, and but again, the number of the recruited people very small.
Very good. Any questions, any comments from our participants? Remember, please feel free to add anything to the Q&A function, any questions you may have or comments. And I think while you're doing that, perhaps we can move on to the next one in the interest of time. So next, please. So the next one I'm presenting, and it's an article out of Quebec, so out of Canada. First author is Kilpatrick, and then the colleagues, they include Emily Allard and the team that have done a lot of fantastic research in Quebec in palliative care. This article is entitled Factors That Support Home Deaths for Patients Receiving at-Home Palliative and End-of-Life Care, a sequential mixed methods explanatory study, and it was published this year in the BMC Palliative Care Journal. So the authors in the background highlight that many patients across age groups and diseases receive or wish to receive palliative and end-of-life care in their homes. So they refer to this as at-home palliative care in the article. They highlight the importance of respite care even at the beginning in the introduction part of the article, where respite care is the opportunity given to family members or informal caregivers to take some time off to do what they need to do to look after themselves as well, to take breaks, as it were. So the study goals of the study were to identify the factors associated with remaining at home and home death, or definitive transfer for patients receiving palliative end-of-life care. So transfers from home to, say, a hospital or a palliative care unit or a long-term care facility, nursing home. The second study goal was to explore the importance of these factors from the perspective of the different groups. And these perspectives included patients, care providers, and caregivers, and which is an aspect of this study that I found really interesting. So the methods they used to address their study goals was a mixed methods sequential explanatory design. So basically they used both quantitative and qualitative methods. In this case, they started with quantitative study, and we'll look at that. They looked at the administrative data from a non-government, not-for-profit, at-home palliative care organization in Quebec, in Canada. And they looked at the data from 2015 to 2024, which included over 5,900 patients cared for by this not-for-profit at-home service provider. So that was the quantitative piece, the administrative data collected. And then what they did was they followed up with the qualitative piece, which included 73 semi-structured interviews. And these interviews were 60% of the interviewees were patients and caregivers, and then 40% were healthcare providers. So I really like the study design where the qualitative follows up on the quantitative to explore in more depth the findings that they found in the quantitative. Next. So in terms of the key results in the quantitative component of the study, 26% of patients lived alone, and the overwhelming majority had cancer. So it looks like this team focuses more on cancer care, as 94% of their patients had cancer. The mean number of home care contacts, or services as they call them. The way I read it was the number of visits is another way of putting it, or other forms of contact, were 31.4. Now, 25% of the patients under their care received 3 or fewer contacts. So the majority were many contacts, and in fact, there were some with hundreds of contacts. So the contacts, I understand it to be not just the visits, but also telephone support. Home death occurred in almost 30% of cases, and the time from admission to their at-home program, to a home death was a mean of 89 days and a median of 32 days. So it varied quite significantly, with some into the hundreds of days. Now the key findings: the factors associated with home deaths were access to respite care. So if there was respite care put in place, the patient had a 2.7 times higher possibility of dying at home. Whereas if they were living alone, the probability of them dying at home was reduced by 50%, which is not surprising. We've seen, we've heard of that before. We've seen that before in practice, but it's good to see this in terms of what the numbers actually are in this particular context. 20% lower chance of a home death if you're receiving psychological care, which is the one piece that did surprise me. And then if you've been hospitalized before, there's a 70% lower chance of you dying at home, which to me suggests complexity and perhaps services. But in this case, there was this one service that specializes in this area. Now, the factors associated with definitive transfers were numbers of services or visits. So the risk was lower of a transfer away from home and into a hospital or other setting as the number of visits increased. So the more the visits, the lower the likelihood of transfers. Psychological care, 1.44 times higher risk of transfer. And then remember the time frame that this was done, it included the COVID pandemic. And so a COVID infection increased the risk almost twofold of people being transferred to the hospital. And then the factors associated with time to definitive transfers. So from the time of admission to the program until they were transferred to a hospital, the slower the time for patients to get respite care, the shorter the time to being transferred. So you're more likely to get transferred if it took a long time to get respite care in place or activated. And if you're living alone, the time to a transfer, not surprisingly, was shorter. Next. So in the qual phase, when they interviewed the various folks, these were some of the themes that emerged. It's important to accept help, including aids such as wheelchairs. Families and caregivers said that there's often a reluctance to accept help. Accept help, look for it. The importance of timely access to home care, especially if in a crisis, was emphasized. They did highlight inconsistency of services across community centers. So the way the system is organized, that there are these community healthcare centers across Quebec. There were, I think, 7 or 8 regions actually involved in this study. So this at-home program reaches out to about 7 different regions in Quebec. And they often connected with a community center. And in the community centers, you have varying makeup of the teams, interprofessional teams, and services offered, including psychology support, grief and bereavement support. And what they did highlight was the inconsistency of these types of services across the community centers. Some centers offered more, others less. The importance of respecting the patient's wishes related to end-of-life and home death, end-of-life care and home death. Contribution of palliative care physicians was important. it was very good, but it varied. And in some cases, now, the one thing that wasn't very clear in this paper was whether the physician is a specialist palliative care physician or whether the physician is a primary care clinician who's providing palliative care. At the end of it, contact with the physician was important, but did vary a lot from region to region. In terms of the strengths, the study design itself, I think, is a strength. And in terms of the limitations, this was limited to a urban area or urban areas in one of Canada's provinces. And then also things were upended a bit by the COVID-19 pandemic. I asked the question, what about patients who did not receive at-home palliative care? It would be interesting to look at what happened to them. So in terms of the key discussion points in practice impact, I think the study highlights again important factors related to palliative and end-of-life care at home and dying at home. Some of them we already knew before, but this has just confirmed that even further. The importance, for example, of respite care and nursing care to meet the needs such as hygiene, pain, and symptom management. Psychological support and holistic care was emphasized in the paper. And the model that they spoke about consists of what they refer to as a stable home care team with quality nursing care, some respite care, and then psychological care and volunteer support as well. And that is the article. Any thoughts?
Thanks, Jose. I think, we all know how much of care falls to the caregivers, right? Unpaid caregivers. And so the importance of respite care isn't obviously surprising, but I'd be curious to know what they included in that, what type of level of care is this? Could that include like volunteers and companionship to give a loved one a break, so they can, manage their own health and things that they need to do just for daily living? Or is this more like nursing level care to support the clinical needs of the patients, so still to give a break? But I'm just curious if there was any details on what respite was, and assuming that's
Yeah.
respite in the home, but we also have out of home respite that I think is under utilized in palliative care.
That's a good point. I don't remember seeing any discussion about respite care outside the home. So, for example, respite care offered in hospices or some other, or some nursing homes. It would have been nice to have seen a bit more details about the model. And I'm wondering whether, we see now in quality improvement articles, for example, where there's a checklist of information that you need to include so that we can interpret the findings better. And it might be good to have sort of a checklist in the future of what information to include so we're able to compare it with our own services and develop similar services in the future. I mean, for example, a few months ago, we published that article on the consulting shared care taking over model. Well, we don't know to what is the involvement of the primary care provider in this model versus the specialist palliative care team.
Yeah, thanks, Jose. I had the same question as Leonie, just a desire for a little bit more detail. The other things I wondered about, so this is a not-for-profit home palliative care organization. I wondered, is this the norm for delivery of home palliative care in Quebec, or was there something special about this organization? And when I was initially reading it, I thought that this was like home care, but later in the discussion, it appears like home care is separate from this team. So this is more like a specialist, like a home-based specialist palliative care team on top of home care. Anyhow, yes, it was a bit unclear to me as with respect to the model.
Yeah, I totally agree. And I think in the future we need to maybe from this journal watch, someone can develop a checklist of the type of information that we need in these type of papers so that we can compare them. In terms of the model, I try to read that up. And I'm reminded of in Ontario where there are nursing home agencies that are basically not for profit. There are also some profit ones, but they're non-profit that are contracted by the public system to provide home care. So I'm wondering whether that's the model. So it is an agency that's not for profit, but contracted by the public system, the government, and wasn't sure totally about the model. Very good. Any comments or questions? We've got a very quiet group of participants today. I don't see anything on the question and answers, no comments, nothing in the chat. Do use that, please. We get some really good discussions from those. And while we wait for some comments, either on the first paper or the second one, let's go on to the next one. And the next one is Sharon.
Yes. So I'm presenting a paper entitled Prevalence of Preoperative Palliative Care Needs in Association with Healthcare Use and Cost Among Older Adults Undergoing Major Elective Surgery. The authors are Min et al., and this author group is based in the US. And the paper was published in the Journal of the American College of Surgeons in July 2025. So the background to this study is that up to 40% of older adults with serious illness undergo surgery, and this population is known to be at risk of greater pain and depressive symptoms with higher functional and care partner needs. The American College of Surgeons recently endorsed a national consensus guideline on quality palliative care, including a recommendation that palliative care be provided to adults with serious illness undergoing major surgery. At this point, little is known about the prevalence of palliative care needs in this population and the association of these needs with healthcare utilization and costs. So with respect to methods, this study drew upon two data sources. One was the Health and Retirement Study, or HRS, and this is an ongoing longitudinal study that interviews older Americans who are community dwelling, and it's conducted every 2 years. It gathers detailed information on sociodemographics, wealth and income, as well as functional status and symptoms, and also caregiver needs. So the time frame of the study was 2007 to 2019, and it was linked to fee-for-service Medicare claims. The specific study population included adults of 66 years of age or older who underwent major elective surgery within 2 years of their last HRS interview. And major elective surgery was considered any therapeutic intervention that involved an operating room and anesthesia, and it excluded emergency or urgent surgeries. And from this population, they extracted data on exposures and outcomes. So exposures were the presence of serious illness, and that included being 85 years of age or older, having a functional cognitive disability, diagnoses such as cancer, chronic pulmonary, cardiac, liver, or renal disease, presence of dementia, frailty, and living in a nursing home. The preoperative palliative care needs that were extracted were presence of pain, depressive symptoms, functional dependence, and care partner needs. And care partner needs meant that there were hours of unpaid caregiving. And the outcomes that they looked at were healthcare utilization and costs during the 1 year after surgical admission. Covariates were age, sex, ethnicity, and marital status. And in their analysis, they compared older adults undergoing surgery who did not have a serious illness, those who did have a serious illness without palliative care needs, and finally those with a serious illness and palliative care needs. And they did comparisons and also uni and multivariable regression analyses for associations. Next slide, please. So the key results, about 2,500 older adults were included, of whom 63% had a serious illness, and of that group, 78% had palliative care needs, and those included moderate to severe pain in about 50%, major depressive symptoms in about 30%, functional dependence in about 12%, and unpaid care in about 25%. So older adults with serious illness and palliative care needs versus those who did not have a serious illness had a higher rate of postoperative complications, longer length of stay, higher rate of ICU admissions, and were more likely to be discharged to a non-home location, as well as a higher one-year mortality. Older adults with serious illness, the presence of serious illness was independently associated with increased total hospital days, hospital readmission, and ED visits over the 1 year after the surgical admission. Those older adults with serious illness and palliative care needs had significantly higher rates of healthcare utilization, and they were the highest in those who had depressive symptoms. The presence of serious illness also incurred higher healthcare costs at 90 days and 1 year. And those older adults with serious illness and palliative care needs, especially depressive symptoms, incurred the highest costs. So the key discussion points were that this study represents one of the first efforts to systematically characterize older adults with serious illness undergoing surgery and examine modifiable palliative care needs and their impact on the healthcare system. It also highlights the importance of early identification of at-risk older adults so that appropriate palliative care interventions may be administered perioperatively to mitigate downstream repercussions. Next slide, please. So the main strengths is that the data were extracted from a nationally representative and regularly occurring survey. Limitations are that this survey does nonetheless incur selection bias, so the findings may not be generalizable. The only costs that were accounted for were those to the healthcare system and not to patients and their caregivers. The design of the study does not allow us to make causal inference regarding the independent effects of specific palliative care needs on outcomes. The data on palliative care needs was limited to what was collected in the surveys, so we don't have information, for example, on symptoms besides pain or depression or on overall quality of life. There is a lag time of up to 2 years between the interview and surgery, and we don't have information about what may have happened in between, and the authors do not discuss who should address palliative care needs, although it seems to be implied that it's specialist palliative care. So the practice impact is that elective surgery does present an opportunity to screen older adults with serious illness for palliative care needs, and integration of palliative approach to care in the surgical setting with specialist palliative care for more complex situations is warranted. So I'd be interested in my colleagues' comments on this study.
I found the study very interesting because it's a population group that I know I personally often forget about, although ironically, I've had some family experiences of this patient population. They excluded patients who underwent emergency or urgent surgery. And I wonder whether there probably is a very large group there of patients who've got palliative care needs. I mean, we hear stories,
Yes.
even amongst family members, of someone who very frail, has a fall, goes for a hip surgery, and then dies a few weeks later.
Mm-hmm. Yes, absolutely. That is, I think, the need for urgent or emergency surgery does indicate a higher risk group for sure.
Thank you. There's some comments coming through. Maybe what we'll do is we'll address those comments after Leonie's the paper, the last one.
Great. We can
Yeah.
go to the next slide. Thanks. So this last paper that we're going to discuss is entitled Proportional Sedation for Persistent Agitated Delirium in Palliative Care, a Randomized Clinical Trial. It's by David Huey and colleagues, both other colleagues in MD Anderson, Texas, in the UK, in the US, sorry, and as well as other groups in Taiwan. And it was published in July 2025 in JAMA Oncology. So background to this paper, and I think very familiar to many of us in palliative care, that delirium is obviously very common and is a highly distressing symptom that affects over 90% of patients in the last days to weeks of life. And of those, about 50 to 70% develop hyperactive kind of delirium symptoms of restlessness and agitation that in the last days of life is often irreversible, and non-pharmacologic measures are often inadequate to manage the symptoms properly. Um, Neuroleptics and benzodiazepines are both often prescribed for patients who have persistent agitation in those last days of life, but there's been much debate over the risks and benefits of these classes of medications, with lack of high quality evidence and mixed findings of studies that we do have. Interestingly, this study also builds on an earlier trial that David Huey and Eduardo Barrera had done, that was published in 2017, that looks at the addition of a single dose of lorazepam onto haloperidol or haloperidol versus haloperidol alone for agitated delirium at the end of life. That did show significant reduction in the level of agitation just with that one dose. But in this paper, they go on to say that, there are other ways of addressing this persistent agitation at the end of life, and they use the term proportional sedation for the different ways that this can be approached, including either escalation of the usual neuroleptic dose, rotation to another class, such as benzodiazepines, and then adding a benzodiazepine to a neuroleptic in combination. And that there's been no randomized control trial that's addressed kind of these three different strategies for managing persistent agitation against placebo. So the aim of this study was indeed to compare the effect of escalating haloperidol as a single agent, rotation to lorazepam as a benzodiazepine, and then a combination therapy with both haloperidol and lorazepam versus placebo, and specifically looking at restlessness and agitation in those at end of life with advanced cancer in a palliative care unit. So this was a multi-center, double-blind, parallel group randomized trial design that was held at 3 different acute palliative care units, as I described, in Taiwan and the US, over a 4-year study period from July 2019 to June 2023. Inclusion criteria was for adults 18 and over who had advanced cancer who were admitted to a palliative care unit. They had to have delirium that was with persistent restlessness and agitation that had a Richmond agitation symptom score of at least 1+, despite regular non-pharmacological therapies and standard dose haloperidol of at least 4 milligrams per day in the past 24 hours. The intervention arm was again 4 parallel processes. So you either receive scheduled haloperidol of 2 milligrams every 4 hours, plus 2 milligrams every 1 hour as needed. Lorazepam, which was 1 milligram every 4 hours, plus 1 milligram every hour as needed, and then a combination of the same doses of haloperidol plus lorazepam, or placebo given every 4 hours. The medications in all these 4 groups had identical volume and appearance, so there was no ability for caregivers or staff to know what medication was given in the blinded part of the study. And they monitored until either discharge, death, or study withdrawal up to 30 days after they entered the protocol. Randomization was in a 1-to-1-to-1-to-1 ratio for the 4 groups that was stratified by site as well as RAS score. At enrollment, all patients were initially started on an open label protocol of Haldol using 2 milligrams IV every 6 hours, as well as 2 milligrams every 1 hour. And then they were monitored for persistent agitation, restlessness until their RAS was +1. And if it was +1 or greater, then they entered the blinded phase of the study medication, as I've just described. Their primary outcomes were change in the RAS score, so level of agitation during the first 24 hours. And the secondary outcomes were the use of rescue medications, but that included either neuroleptics or benzos, depending on which arm of the study they were in, for breakthrough restlessness or agitation during the first 24 hours. the proportion of patients who with a target RAS of 0 to -2 during the first 24 hours, the proportion of patients achieving what was considered a treatment response, which was a reduction of their RAS by at least 1.5, which was felt to be clinically significant based on other studies, and change in the delirium severity as measured by the Memorial Delirium Assessment Scale score at both 0 and 24 hours. They also looked at the proportion of patients who were perceived as being comfortable independently by nurses and caregivers, and also the number of adverse events and documented overall survival. Next slide, please. So the key results, there were just under 3,000 people screened, and of those, there were 8% or 245 who were deemed eligible for the study. Of those, 111 were enrolled and randomized, so 45%. And as I described, so then they enter the open label phase of the trial once they're enrolled. And of those, 68% or 75 of them went on to develop breakthrough restlessness and agitation that allowed them to proceed to the blinded treatments. So, essentially just over 30% were able to have their symptoms well managed on haloperidol alone and didn't require to go on to the blinded phase of the study. The primary outcome analysis included 72 patients, and the mean age was 64 years. Just over half were male. The median delirium severity score was 24, and it's positive above 15. And there was no difference in baseline characteristics between the two groups. Sorry, between the four groups. When we look at the primary outcome results, again, just a reminder, this is the RAS score change at 24 hours after entering the blinded treatment. The lorazepam group and the combination of lorazepam and haloperidol both had significantly lower RAS scores than the haloperidol group alone. And there was no differences between the lorazepam versus this combination group and between haloperidol and placebo. When you look at the secondary outcomes, there was significant numbers of rescue doses in the placebo specifically compared to combination group lorazepam and haloperidol alone. You can see the percentages vary from 30 to 50%, but overall those who had a scheduled medication required fewer rescue doses than those who only had placebo. There was no difference between delirium severity scores or the type and number of adverse events. There was some hypertension and hypoxia, but their survival was in short days, and so this they felt could be attributed to typical changes that would be seen at end of life rather than the drugs themselves. And the difference in length of survival wasn't different between the groups. Interestingly, the perceived comfort was significantly different between the combination and the lorazepam groups, which were both perceived to be more comfortable than haloperidol alone and placebo. Next slide, please. So key discussion points. I mean, there's a lot to talk about in this article, but I think the main thing is that lorazepam alone and in combination with haloperidol was superior to haloperidol alone in reducing agitation and restlessness in patients who had persistent agitation from delirium at the end of life. They had both lower RAS scores, which is the intensity of agitation, and fewer breakthrough doses for episodes of restlessness and agitation, and greater perceived comfort by both caregivers and nursing team. Those who received the scheduled medications, including haloperidol alone, received significantly fewer rescue medications compared to placebo, which may suggest that scheduled medications may represent a more proactive approach to preventing breakthrough restlessness and agitation in this setting. And I also wanted to note that there was a group of people who received haloperidol alone that never entered the blinded phase, as we've discussed. So they, 30% of the folks who were enrolled in the study actually didn't need to go on to have anything added to haloperidol. So although the in-depth review here is focusing on those 4 blinded groups, there were a number of people who benefited from haloperidol alone. So that's important to note as well. So the strengths were that this is a double-blind, multi-center randomized parallel group trial. I like that they measured the restlessness and agitation itself as the primary outcome, not as many studies have done the severity of delirium. The limitations is that obviously it's a very specific context where we're talking about delirium only at the very end of life. These were on average people who lived about 4 days, and they were on a specialist palliative care unit, so may not be generalizable to other settings or delirium outside the end of life. They didn't examine other medications that are commonly used for delirium and agitation, such as injectable olanzapine, for example, and they only examined the intravenous route, whereas we know across jurisdictions and settings of care, its subcutaneous route is much more commonly used in palliative care. So I do think this does have a practice impact for us to consider that really proactive use of scheduled lorazepam may reduce persistent restlessness and agitation in patients with advanced cancer and delirium at the very end of life. I'm very curious to see what people have to say, and I know we're short on time, but if we could take a couple minutes before we do the honorable mentions, that would be great.
I agree. I think this deserves a discussion. And even if we refer people to the honorable mentions online and have a good discussion around this would be excellent. Sharon?
Yes, well, definitely a thoughtfully designed study. And one thing I wondered about is, so they measure their outcomes at 24 hours, but is it implied that those outcomes persist?
So they didn't. I can't speak to that beyond 24 hours because
Okay.
they didn't measure all of the scores regularly beyond that.
Mm-hmm.
So again, I guess should have said that's actually a limitation that we're only looking at those 24 hours.
Right. Yes, I wondered, did any of them eventually need palliative sedation, or was this sufficient? But I'll let others comment.
It's interesting you say that because one of the questions that came up for me was definitions of proportional sedation versus deep continuous sedation. And I know for some there've been some studies or papers published recently exploring how different people understand it differently and how we need to come up with some standardized definitions. When I read the paper, I thought, oh, this confirms my practice of for someone needing palliative sedation. In other words, intractable, agitated delirium, they need palliative sedation. And in my clinical practice, the starting point usually is the lowest dose possible to achieve comfort at the lowest level of sedation possible, and then titrating it to effect. So for me, they seem to meet those criteria. Although sometimes, as they highlight in the paper, some patients may need a deeper level of sedation from the outset.
Yeah,
So,
it is interesting terminology because, in Canada we use our palliative sedation is a proportional
symptom.
to symptoms and it's not a deep continuous sedation by the guidelines we've developed. But I think there is a difference here in the use of or the addition of sedative medications for symptom relief versus it's truly refractory to usual measures. So could we consider that adding a lower dose benzo to a neuroleptic, for example, or just using it alone is a usual symptom management measure as opposed to palliative sedation? I think that needs a bit of exploring in our practices because I wouldn't consider adding a low dose benzo like consistent with continuous palliative sedation therapy. But I'm curious, Sharon, what you or Yoko, what your thoughts are.
This type of the practice quite applicable in I found that the people dying in the home. So the continuous palliative sedation is probably not done a lot in a home setting, but small dose of the lorazepam in addition to concurrent symptom management. So I was really curious that, as Sharon mentioned, that how many of those people required continuous sedation, but I really don't really get how these people come to this small selection of the medication only to the last 4 days of life. And also the other symptom burden and opioid use, such as I'm just curious about that.
Yeah, they didn't do, or at least they didn't in this study report MEDDs or anything to look at average opioid use or other adjuvants.
Yeah.
The one finding I found interesting was that they recorded or reported Karnofsky scores, so scores of functional level. And I mean, for someone requiring palliative sedation, in other words, at the very end of life, an intractable symptom, you'd expect a Karnofsky to be low, like 10, 20, 30. But there were some that were at 40, Karnofsky 40. And in some of the groups, it was like I think in one of the groups, a third of the patient, almost a third, had Karnofskys of 30. So, which makes me wonder whether there's sedation occurring sooner. But I think that the key thing here is intractability and trying to address the suffering.
Yeah, I don't know that I would say if it's intractable agitation or restlessness if they've only had the open label portion of haloperidol, right, which is a fairly low dose, 2 milligrams Q6. By my definition of palliative sedation, I wouldn't think that was a refractory symptom. So they did have kind of like persistent agitation and restlessness that required either escalation of their neuroleptic or the addition of a benzo. Yeah, it's so much more to talk about.
Yeah, maybe it's next
Yeah,
time we
yeah,
invite folks in, and
yeah.
maybe we can get some from the group there to be part of this and
Yeah, it'd be
help
great.
us understand the paper further. There is a fascinating remark by Ben Robert online. He writes, "I find agitated delirium is not uncommon with people dying from dementia," and Ben works in the long-term care homes, "particularly when their usual oral psychotropics, the antipsychotics and SSRIs, are not replaced parenterally." So he's wondering whether it's a withdrawal syndrome. In other words, he's just making an observation there that perhaps there's more agitation at the end of life because people are no longer able to swallow, those who are presumably with dementia, and I presume complications like frontotemporal dementia with agitation. So just something to consider. Thanks, Ben. And then we did respond to some of the questions in the Q&A already online, so please do look at our answers over there. We're at the top of the hour, past the top of the hour, so it is time to end. We thank you for joining us today. Again, please remember to go back and share the episode and the podcast with colleagues. Our honorable mentions also across a spectrum of topics. The first one is a retrospective cohort study looking at pregabalin versus gabapentin in the development of heart failure. This is not in palliative populations, but it does remind us to think about this possible complication. In fact, in the study, what they found was that patients started on pregabalin at higher incidence of heart failure versus those with gabapentin. The next one by Chang and colleagues published also in the JAMA Network Open, looked at referral criteria for specialist palliative care for patients with dementia. And so through a Delphi process, they identified 15 major criteria, and I think there were about something like 42 minor criteria of when you should consider referring to a specialist palliative care team. The next study by Wheatman and colleagues looks at improving specialist palliative care discharges from hospitals and hospices to community settings, and this was published in the BMC Palliative Care. And if that's the setting you're working in the hospital, please do look at this because it reminds us again of good practices that we can do to ensure good transfers of patients from one setting to another. The next paper by Al Jawari, published in the Journal of Clinical Oncology, is a good reminder for us that even patients undergoing hematopoietic stem cell transplantation will experience palliative care needs, and we shouldn't forget that population. And the last one I really enjoyed, and because it relates to quality improvement, and it's basically the experiences of a cancer center, cancer service that asks itself, how can we improve palliative care within our service? And then it describes the process of going through that in current oncology. So we encourage you to go look at these papers as well. And with that, next please. With that, I want to thank Leonie, Sharon, and Yoko for joining us today. I want to thank Angaran, who tried to join us, to provide some input and helped us select the papers. And again, a special thank to the various teams across the different divisions for their contributions to the Journal Watch. And with that, thank you very much, and have a good day or good evening or the rest of the good morning, wherever you're at. Thank you. Bye-bye.